Hello people, how are you? In this video, let us look at some MCQs on this topic ear. Okay, so let us look at some MCQs. Otosclerosis affects which bone? So you saw the answer already. Otosclerosis affects mostly the stapes bone. Okay, so where is the stapes bone? Here. Okay, so this is the stapes bone. Here otosclerosis mostly. Okay, let's move on. All are tuning fork tests except. What do you think the answer is? Schwabach's test you have seen is tuning fork test, Rene's test, Weber's test, all tuning forks test. So answer here is B. Right? Okay. Then next question. Which of the following causes the opening of eustachian tube? So which muscle, or they are asking what causes the opening of eustachian tube? The answer is C. Tensor veli palatini. That is the muscle. Where is this tensor veli palatini? Let us look at that. Have they shown the muscles here? Yeah. This is the eustachian tube. So the muscle that makes it open is tensor veli palatini. So guys, this tensor veli palatini is here. From the palate it is going. See? Tensor veli palatini. And this is the eustachian tube. Okay. So you should not get confused with tensor tympani. The muscle that opens it is tensor veli palatini muscle. Okay. So let us see the answer. Answer is C, tensor veli palatini. Now let's move on. During the examination of the ear, during ear examination, cough occurs due to stimulation of. So when you are examining the ear, the cough occurs. Why does it occur, guys? Cough. So why does this cough occur? What do you think the answer is? The answer is D, vagus nerve. Okay. Shall we move on to the next question? Okay. Ramsay-Hunt syndrome. In Ramsay-Hunt syndrome, all are true except. So what is this Ramsay-Hunt syndrome first of all? Because of herpes zoster, I think so, yes. Seventh nerve is involved, that is nothing but facial nerve, right? Facial muscles are involved, seems about appropriate. Okay. Facial vesicles are seen. On the face, are there any vesicles? I think this is wrong. The vesicles are not on the face but elsewhere. What do you think? Yes, the answer is C. This is wrong. Why? Because if you see Ramsay-Hunt syndrome, there is facial muscles are affected, yes, but the lesions, the vesicles, whatever they are telling, they are in the ear, oral cavity, tongue. So basically here the answer will be facial vesicles are not seen. Facial vesicles are not on the face. So herpes zoster is the virus. Yes, that is correct. So where and all you will see the vesicles? Pre-auricular skin, behind the in front of the ear pinna, right? Pre-auricular skin of the ear canal, soft palate, but it is not on the facial skin. Okay. Next question, guys. So how is it going till now? Are you able to get some idea? Okay. So you are able to solve also? Okay, good. So let's continue. So which fracture of the petrous bone will cause facial nerve palsy? Which fracture of the petrous bone? Longitudinal fracture, transverse fracture. Okay, facial nerve injury. So basically which fracture? So this seems to be one of these, and in this the most common is B. That's what they are saying, transverse fracture. So what is transverse? Like horizontal type of a thing, right? That is transverse. Okay. So facial nerve palsy, fracture of petrous bone, both of these can cause. Okay, but transverse fracture is more common. That's what they are saying. What is this fourth option? Facial nerve injury is always complete. What is this? Okay, let's move on to the next question. Facial nerve palsy is seen in sarcoidosis, varicella zoster virus, is it? Acoustic neuroma, all. Facial nerve palsy is seen in varicella zoster. Okay, that's the zoster. We saw some question with herpes zoster, right? That was Ramsay-Hunt syndrome. Okay, so the answer here is all. Okay, all of these can cause facial nerve palsy. What is sarcoidosis? So sarcoidosis is growth of tiny collections of inflammatory cells in different parts of the body. So inflammatory cells, multiple organs. Granulomas will be there. But why is this? What is this acoustic neuroma? So this acoustic neuroma is nothing but vestibular schwannoma neurilemoma 8th nerve tumor. So some tumor on the 8th nerve this is, okay. Guys, this acoustic neuroma is a very important topic, okay. So let's note this. It's really an important thing. So in all these cases, they can be facial nerve palsy. That's all we had to answer here. Let's move on. Okay, here. Fraze syndrome is due to the involvement of. Fraze syndrome you have seen, guys, right? That when they eat, they sweat. If you remember this, see. So when they eat, they sweat. Why does this happen? This patch of skin, parotid gland, the nerves have got mixed up. Which nerves have got mixed up? The auriculotemporal nerve, which is a secretory motor nerve, right? So this is supposed to secrete. It joins up with the great auricular, which is a sensory nerve. So great auricular and auriculotemporal have got joined. Okay. So Fraze syndrome is due to the involvement of which nerve? Auriculotemporal nerve. Yes, let's see the answer. Yes, it is auriculotemporal nerve. Okay. Okay, so let's move on, guys. What do you say? Shall we move on to the next question? Take a break, take a deep breath. Okay. Now, schwannoma involves dash, vestibular part of this cochlear. See, schwannoma is a very common word actually, isn't it? That's what we studied in pathology. Let's look at the answer here. They're talking about the ear. So anyways, vestibular part of the 8th nerve. Okay. So if you remember the ear anatomy, go back here. Where is the vestibular part? Here you have the vestibular part, right? Wait. This is the vestibular part of the 8th nerve. Here you have the cochlear part of the 8th nerve. These two will join and become the vestibulocochlear nerve. So they are saying the vestibular nerve, schwannoma. Okay. Then, next question. We saw the answer? Yeah. Next question, guys. Acoustic neuroma. I told you, right? Acoustic neuroma, they seem to be interested a lot about acoustic neuroma. What is it? So basically it is a benign tumor only. So it arises from what? Upper pole displaces what nerves? Lower pole displaces what nerves? So what do you think the answer is, guys? The answer is B. True. What is true? It arises from the vestibular nerve. Actually, if you look at this diagram, here you have the vestibular nerve. Okay, it's going behind this facial nerve. So all this is vestibular nerve, then cochlear nerve is there here. So they are saying this is also vestibular part. This is coming from the ampullus, this is coming from the macula, right? So the acoustic neuroma, they are saying it affects the vestibular, arises from the vestibular nerve. Where were we here? True about acoustic neuroma, it arises from vestibular nerve. Okay. Yes, here they are saying the nerves that it will affect, right? So basically, let us look at some information here. The upper pole will displace 3, 4, 5 and the lower pole will displace, this is what, 9, 10, 11th nerve. Okay. 3rd, 4th, 5th nerves, upper. Lower will be 9th, 10th and 11th nerve. Okay. You can just look at more details about that. Let's move on. The earliest symptom of acoustic nerve tumor. What do you mean by acoustic nerve now? Let's look at the answer here. A. Sensory neural hearing loss. When they are saying acoustic nerve, they mean the entire vestibulocochlear nerve. Okay, the 8th cranial nerve. So they are talking about both the parts here, the cochlear part and the vestibular part. So acoustic nerve means you can consider both that as the 8th cranial nerve. Okay. So here they are saying the earliest symptom will be the sensory neural hearing loss. Okay. Let's move on. Earliest sign seen in acoustic neuroma is, isn't this the same type of question? Reduced corneal reflex. Didn't they talk about they talk about earliest sense? Acoustic nerve tumor. This one they are saying acoustic neuroma. Okay, here the catch is sign. Here they are saying the earliest sign. Sign is something that a doctor catches, right? What about this? This is a symptom. Symptom is what the patient presents with. So he will come with what? Sensory neural hearing loss. What will you find? You will find reduced corneal reflex. Okay. Corneal means what? Something to do with the eye, right? See guys, actually in this, the first thing that will get involved, the earliest nerve to be involved will be the trigeminal nerve. So here there will be reduced corneal sensitivity, numbness, paresthesia of face, etc. So involvement of this nerve indicates the tumor is how much size, etc. So basically this is the earliest sign. Sign here will be the C, reduced corneal reflex. Okay. So is this clear guys? So hope you are learning something. Let's move on. What do you say? In acoustic neuroma, the cranial nerve to be involved earliest is, we already told you the answer, it is the trigeminal, so answer is A, that is fifth cranial nerve. Acoustic neuroma causes, now let's try to answer this one. We have seen so much about acoustic neuroma. Cochlear deafness, retrocochlear deafness, conductive deafness, any of the above. I don't like this any of the above. Let's see the answer. What do you say? See, because sensory neural deafness is the first symptom the patient presents with it, they said. So if there is sensory neural deafness, definitely it is not conductive deafness. So we'll remove this. This is not what we are looking for. So obviously, okay, then cochlear deafness, retrocochlear deafness. Let's see the answer. B. Oh, there is a term called retrocochlear deafness. So this is the answer. Okay. So retrocochlear deafness, guys. This cochlear deafness usually happens if there is damage to hair cells. In many years you can see this cochlear deafness, okay. And in this retrocochlear deafness, retro means what? Very old, some style or fashion from the past, right? Okay, anyways. So basically in this retrocochlear hearing loss, that is in acoustic neuroma, what will be there? Here the sensory neural hearing loss will be more in high frequency. There will be poor discrimination score, 0 to 30%. Recruitment phenomena absent and rollover phenomena will be present. Discrimination score further decreases when loudness is increased beyond a particular point. Short increment sensitivity index, that is SISI. This test will show a score of 0 to 20% in 70 to 90% cases. Tone decay is significant. If you understood it, then great. Otherwise, just remember there is retrocochlear deafness in acoustic neuroma. Okay. So here the one thing that at least you understood is the sensory neural hearing loss will be more marked in high frequencies. Sounds something like presbycusis. Let's move on, guys. Shall we? Okay. Acoustic neuroma, all are seen except loss of corneal reflex. We saw this, no. This is the sign. So this will be there. Facial palsy, not complete, okay guys. So facial palsy won't be there. So acoustic neuroma, don't say facial palsy. Tinnitus, diplopia can be there. Tinnitus very early it will be there. Diplopia will be a late feature, okay. So facial palsy you can rule out, guys. So answer here is facial palsy. So this is kind of, though it has some pressure on acoustic, on the facial nerve, etc. Facial palsy they are not saying is associated, okay. Next question here, in a patient with acoustic neuroma, all are seen except. Again, it's an except question. So facial nerve may be involved, reduced corneal reflex. See, facial nerve may be involved. This is kind of always a maybe with facial nerve, okay. Reduced corneal reflex. Yes, this is a sign. Acute episode of vertigo. So vertigo will not be there, guys. Look at this, answer is D. Vertigo will not be there. Acute episode of vertigo they are not mentioning. So except goes with acute episode of vertigo. Okay. Fine, guys. Cerebellar signs can be there. In acoustic neuroma, the earliest ocular finding is, in acoustic neuroma, the earliest ocular finding. So here the earliest symptom they told you, earliest sign also they told you. They want to know the earliest ocular finding. So what do you think the answer is? Answer is D. You already saw this. Loss of corneal reflex itself is the earliest sign. So that can be the earliest ocular sign, obviously. So this will be the answer. It's not an except question. So let's make it green. Okay, this is the answer. In acoustic neuroma, the earliest ocular finding is the loss of corneal reflex. Treatment of choice for acoustic neuroma. So now we have reached some question on the treatment of this acoustic neuroma. What do you think you will treat it with? Options are steroid, radiotherapy, anti-neoplastic drugs, surgery. So the answer here they're saying is surgery. Surgery is their choice, it seems. According to the textbook, surgical removal of the tumor is the treatment of choice. Surgical approach will depend upon the size of the tumor. Various approaches are there: middle crania fossa approach, translabyrinthine approach, suboccipital, that is retrosigmoid approach, combined translabyrinthine suboccipital approach. So many approaches are there. Surgery is a treatment of choice for what? For acoustic neuroma. Have you seen the neuroma, acoustic neuroma? This one they're saying they will remove it surgically. That's the best thing to do. Next question for you. The usual location of glomus tumor, jugulare tumor. Is there something like this really? Yes, it is there. Glomus jugulare tumor. So you tell the usual location. Where will this location be there? See, in this jugular, what am I seeing? Glomus tumor, right? You have glomus jugulare, glomus tympanicum, and anything else is there. Okay, two they have mentioned here. In what? Basically, this is a benign tumor. Glomus tumor, it's the most common benign neoplasm of the middle ear. It is from the glomus bodies. So why do they have this name? Because they resemble carotid body in the structure which are found in the dome of the jugular bulb. So they named it something like this. Okay. So the usual location of glomus jugulare tumor, we already told you it's a middle ear benign tumor. So what do you think is it? Middle ear means what? It will be not this, not this. So these two are wrong. So what is the answer here? It will be epitympanum or hypotympanum because it has to be middle ear. So the answer here is hypotympanum. Hypotympanum is the answer. Okay. Let's move on, guys. This FISCH classification is used for what? It's used for glomus tumor. What do you say? Yes, answer is glomus tumor. So they are using this FISCH classification. Okay. Type A, type B, type C, type D. So type A is, it's there only in the middle ear. Type D, it has reached the intracranial extension. So it looks like type B has extended more. What do you say? Guys, are you ready to take a few more questions on ear? In cochlear implants, electrode are most commonly placed at. So if you know in middle ear, here you have the oval window and round window. Oval window is where the stapes footplate will go, right? Round window is the fenestra cochlea. So fenestra cochlea means it opens where it round window. See, oval window, stapes. Round window will do what? A small round opening. It is separates the middle ear from the scala tympani. So this is what we want, right? So it should be round window. What is the answer? Round window. See, guys, this one is the scala vestibuli. Middle you have the scala media and down you have the scala tympani. Scala vestibuli you have the oval window. Scala tympani you have the round window. Right? Stapes actually works on oval window. Now they are saying cochlear implant you are giving. So this entire thing you are seeing, this is cochlea. So you are giving cochlear implant. Okay. And they are saying the answer is round window. Okay. Let us see where will you place the electrode. You will place it at the round window. So the electrodes in cochlear implants are most commonly placed at a round window. So basically, it's most commonly only they are saying. Here in this photo, very clearly they have shown that. See, going through the round window kind of a thing. Because stapes is here, you can clearly see it's not on the oval window, it's on the round window. Okay. electrodes they have shown here. It's going through the round window. Okay. Guys, what you should understand in the mechanism of hearing, you have understood how the hearing happens, right? So what happens, the stapes will act on this oval window, then the perilymph will move. So the perilymph where in the scala vestibuli will move. There is displacement of fluid even in the scala media. The basilar membrane, okay, there is a bulging of basilar membrane towards round window. This fluid in tympanic, scala tympani also will move, okay. The movement of the scala tympani fluid also will occur towards the round window. Right, and then this basilar membrane, because of this, there is wave, okay, towards the helicotrema. So basically this is the travelling wave theory. Okay, so round window is where you will place the electrode in cochlear implant. Okay, let's move on. All of the following diseases have a consistent symptom of tinnitus except tinnitus you have seen in Meniere's. Yes, we have seen in Meniere's. So this is a green. We have seen it there. Otosclerosis will have tinnitus. This is what? Chronic suppurative otitis media. Yes, otitis media. See this. I think the answer is mastoiditis, because mastoiditis is somewhere away from the parts we are talking about. What do you say? Let's look at the answer. Yes, answer is mastoiditis. So basically what is mastoiditis? The inflammation of all the lining of this air cells, mastoid air cells. You know what the mastoid is and all that, right? Or should we explain that? Right? So here you have the air cells, right? Behind the ear, that bone, you have the mastoid air cells. Look at here, this is the mastoid process. Inside that you have the air cells. So whenever this gets infected and all, you will have a mastoiditis. So this doesn't cause tinnitus, that is the ringing of the ear. Or ringing in the ear, right? Tinnitus. So that's not happening because of mastoiditis. It can happen because of Meniere's disease. Meniere's disease, what? Endolymphatic hydrops, chronic suppurative otitis media, that is infection of the middle ear can happen. Otosclerosis because of the problem with the stapes being very stiff, right? Can all that, it can cause this ringing of the ear. Pars flaccida of the tympanic membrane is also called as, let's look at this. If you remember our tympanic membrane anatomy and all that, so here you have the anatomy, the tympanic membrane, the parts. You have pars tensa and pars flaccida. Pars tensa is the maximum part. Pars flaccida is this portion. It is also called as shrapnel's membrane. This grey thing. Okay, this is pars flaccida. It's also called as shrapnel's membrane. Okay. So let us look at the answer here. Shrapnel's membrane. Guys, basically, where will you see this Reissner's membrane? Reissner's membrane is in it is Reissner's membrane and basilar membrane. These two are membranes of the scala media. These are the borders of scala media, right? And what is the secondary tympanic membrane? Secondary tympanic membrane is nothing but the round window, right? So secondary tympanic membrane is the membrane closing the round window and separating the scala tympani from the middle ear. So this separates the scala tympani from the middle ear. This is where they are keeping the electrode also for that cochlear implant, remember? Right. Let's move on now. CSF otorrhoea is caused by. So what is this otorrhoea? Some discharge from here? See, otorrhoea is nothing but a discharge from the ear, but here they are talking about CSF discharge. So that is really scary, right? Leakage of the cerebrospinal fluid into the middle ear cavity or mastoid air cells. That's scary. So why can this happen? Your options are rupture of tympanic membrane. I don't think this should lead to some CSF leakage. Fracture of cribriform plate. Cribriform plate. Then what else are the options? Parietal bone. Where is parietal bone? Here on top. Fracture of petrous part of temporal bone. What do you think is the answer, guys? I have a feeling that... Okay, let me not tell my feeling. Answer, I will tell you. Answer is D. Fracture of petrous temporal bone. Oh. Okay, answer is the fracture of petrous temporal bone. Guys, if it is congenital CSF otorrhoea, then you can go for something called as this fissure. Okay. But here they are not talking about the congenital. Okay. They are saying cerebrospinal fluid otorrhoea. This can be there in temporal bone fracture. That is the petrous part of temporal bone. That is this part. right? This is the petrous part of temporal bone, right? So basically this part of it, if it is fractured, then it can lead to cerebrospinal fluid otorrhea. According to the textbook, it is in the longitudinal fracture of the petrous temporal bone. Longitudinal means how it will be? This one, axis of longitudinal fracture. Okay. Better to read some standard books for this information. Okay. Now let's move on. Seagull speculum is use of seagull speculum during an examination of the ear provides all except. So here it's an except question. What are they not using it for? So 3 options are correct. Assessment of the movement of tympanic membrane, removal of foreign body. Oops, answer is visible. Okay. As applicator of the powered antibiotic of ear, so you can use it as an applicator. You can use it to assess the movement. You can use it for magnification, but you cannot use it for removal of foreign body from the ear. See, if you remember, we have seen this seagull speculum here, right? So they are trying to see something inside. So you can definitely magnify. So you can assess the movement. You can use it to apply powdered antibiotic. Okay. But you cannot remove any foreign body from the ear. Okay. So congratulations guys, you have finished this ear MCQs video. We just looked at a few MCQs only. Still so many MCQs are there. We will take them up slowly. Okay. That's all for now guys. Bye bye.